Hi, my name is Brittany Larson. I'm a registered dental hygienist and I'm currently a student at Plaza College completing my bachelor's degree. Today, we're going to be talking about oral cancer in high risk groups. What is oral cancer? Cancer is often defined as a disease caused by an uncontrolled division of abnormal cells in part of the body. Cancer that forms in tissues of the oral cavity or the oral pharynx is also known as oral cancer, which can also be the subgroup of head and neck cancers. If it's detected at an early stage and treated, oral cancer is quite common and frequently curable. Oral cancer can occur on the lips, gums, tongue, inner lining of the cheeks, roof of the mouth, or the floor of underneath the tongue. Some signs and symptoms of oral cancer are a sore on the lip or in the mouth that won't heal, pain in the mouth that doesn't go away, a lump or thickening in the lips, mouth, or cheek, a white or red patch on the gums, tongue, tonsils, or the lining of the mouth, a sore throat or a feeling that something is caught in your throat that doesn't go away, trouble chewing or swallowing, trouble moving the jaw or tongue, and numbness of the tongue, lip, or other areas of the mouth. Swelling or pain in the jaw, dentures that start to become poorly fitted and uncomfortable, loosening of the teeth or pain around the teeth, your voice can change, a lump or mass in the neck or the back of the throat, weight loss, and severe pain in the ear. The causes would be related to flat, thin cells, which are called squamous cells, that line your lips and the inside of your mouth. It's where cancer most frequently starts. Squamous cell carcinomas make up most oral malignancies. The alterations in squamous cells that result in the mouth cancer are not understood, but medical professionals have identified some elements that could raise the risk of oral cancer. Some risk factors which can contribute to a patient contracting oral cancer. The individual's age or family history, those are something that are not changeable for the patient. Any type of tobacco use, including snuff, chewing tobacco, cigars, pipes, cigarettes, and cigars, amongst other tobacco products. Heavy drinking, getting too much sun on your lips without using SPF. HPV 16 is actually a known risk factor for it as well, and a lower immunological response. Who is most likely to get it? This is the high risk groups. So, gender can play a role with this. Men are twice as likely to get oral cancer than women. This may be because men have a history of using alcohol and tobacco at higher rates than women do. Men are also more frequently affected by oropharyngeal malignancies linked to HPV. Excess body weight and poor nutrition can affect the chances as well. Oral cancer appears to be more common in people who are overweight. Consuming more plant-based foods such as whole fruit and no starchy vegetables may aid in weight loss and lower the risk of cancer brought on by malnutrition. Cancers of the oral cavity and oral pharynx usually take many years to develop, so they're not common in younger people. Most people with these cancers are older than 55 when the cancer is first found. HPV-linked cancers tend to be diagnosed in people that are younger than 50, though. Ultraviolet light, such as sunlight, can create added exposure to oral cancer. People who work outside and are frequently exposed to sunlight are more likely to develop cancer on their lip. Fanconi pneumonia. People with this syndrome often have blood problems at an early age, which may lead to leukemia. They could also have a high risk of cancer in the mouth and the throat from this condition. And then from dyskeratosis congenita, this is a genetic syndrome that can cause aplastic anemia, skin rashes, and abnormal fingernails and toenails. People with this syndrome also have a high risk of developing head and neck cancers, especially of the mouth and throat even at a young age. The clinical diagnosis, how much cancer is present in the body is determined by the cancer stage. It helps evaluate the cancer severity and the most effective course of treatment. When discussing survival rates, doctors also refer to the stage of the malignancy. So stage 0 refers to the early stages of the oral cavity and oral pharyngeal cancer. Then there are stages 1 through 4. The less the number is, the less the cancer has spread for the patient. A high number such as stage 4 denotes that the cancer has progressed more widely and kind of speared away from its local spot that it started. A lower stage is indicated by an earlier letter inside of a stage. Although every person's experience with cancer is different, tumors at similar stages typically have similar prognosis and are frequently treated in a similar manner. They also use this scale. So they go by the extent of the tumor, which is indicated as the letter T, how large the main primary tumor is, and if any tissues in the oral cavity or oral pharynx has it spread to. The spread to nearby lymph nodes is indicated by a capital N. Has the cancer spread to nearby lymph nodes? If so, how many? And are they on the same side where the cancer started? How large are they? The spread, which is metastasis, to distant sites, which is indicated by a capital M. Has the cancer spread to distant organs? The numbers or letters after T, N, and M provide more details about each of these factors. Higher numbers mean the cancer is more advanced. Once a person's T, N, and M categories have been determined, this information is combined in a process called stage grouping to assign an overall stage. Treatments for oral cancer. For many cancers, surgery is frequently the first course of treatment. Depending on the location and stage of the cancer, various surgical procedures can be used to treat oral pharyngeal and oral cavity cancers. Small early stage tumors that have not spread are the ones that use it more frequently. Reconstructive surgery may be performed to help improve the appearance and functionality of the areas that is impacted by the cancer, or cancer treatment after the cancer has been removed. So these are just some types of treatments that they have. They have a tumor resection, which involves the removal of the entire tumor as well as the margin, which is the edge that surrounds the tissue that seems normal. In order to decrease the possibility of any cancer cells remaining behind, the margin of healthy tissues are removed as well. Mohs micrographic surgery is also known as micrographic surgery. It's a method that can be used to remove some lip cancers, such as those that are located just at the border of the lip. Slices of the tumor are removed one at a time. Each slice is immediately examined under a microscope to check for cancer cells. Slices are taken out and inspected until no signs of malignancies are found. Glossectomy is a removal of the tongue. Only a little portion of the tongue, less than 1/3, may need to be removed for minor tumors, which is called a partial glossectomy. The entire tongue may need to be removed for more serious malignancies, which is a total glossectomy. There is also mandibulorectomy, which is removal of the jawbone. All or part of the jawbone is removed by the surgeon. If the tumor has penetrated the jawbone, surgery may be required. When a tumor near the jaw is difficult for the doctors to move during an examination, this frequently indicates that the cancer has spread to the jawbone. There's also a maxillectomy. This procedure leaves a hole in the roof of the mouth that could be filled with a prosthesis, a special type of denture. A dentist with advanced training in prosthetic dentistry constructs this. It's called an obturator. A piece of muscle from the forearm or thigh, as well as skin grafts, are other alternatives for bridging this gap. And then a laryngectomy. This is very rare. A person's normal ability to swallow may need to be compromised during surgery to remove big tumors from the base of the tongue or the oral pharynx. Food may pass into the trachea and reach the lungs, where it may result in pneumonia. The voice box larynx has also been removed during this procedure, as the cancer removal when there's a high possibility of this happening. So very important for us as dental hygienists to know the preventions and screenings. Dental exams and cleanings are very important to have done every 6 months, as we know. During this exam, the dental hygienist will do a full EOE and IOE exam. IOE, we're checking all the parts inside of the mouth, such as the lips, philtrum, tubercle, the vermilion border, vermilion zone, labial commissures, parotid papilla, linea alba if it's present, lingual frenum. Those are just some examples of what we check for, as we know when we learned in clinic. And then EOE, you're checking all the lymph nodes. So post-auricular lymph nodes, pre-auricular lymph nodes, submental lymph nodes, the cervical chain, the parotid gland, submandibular glands. This is very important because these are high areas as to where oral cancer can derive from. If the clinician is unsure of something found in the mouth, we are to report to the doctor, and they most likely refer the patient to an oral surgeon or a pathologist for further evaluation to make sure that treatments are caught, the cancer is caught at an early age, and we can treat the patient. This is just some examples of how you can reduce your risk. Visit a dentist for regular checkups, check your mouth regularly at home, avoid smoking, drinking, drink alcohol in moderation, protect your skin with sunscreen. SPF is very important. Look after you brush your teeth and mouth. Don't delay in seeking advice from a dentist or medical professional if you notice something unusual in your mouth. And this is kind of just a picture of EOE and IOE done. The survival rate for oral cancer is relatively high. Early detection of cancer increases the likelihood that you will survive and you can resume normal activities. On the other hand, survival rates significantly drop if mouth cancer spreads to any other areas of the body. This is why it's important for us to be able to catch these cancers when they are very tiny. Survival rates can widely vary depending on the original location and the extent of the disease. So this is just a little bit of an assessment just to go over what we discussed. Which of the following may be obstacles to early detection of oral cancer? Warning signs or manifestations of more advanced disease. Early oral cancer is generally asymptomatic and may be difficult to see. The oral cancer exam may not be done enough by clinicians or their patients at risk, or all the above. The answer is all the above. We want to make sure we know all of those. Behaviors that have been shown to increase the risk of developing oral squamous cell carcinoma include cigarette smoking, heavy alcohol consumption, cheek biting, A and B only. The answer to this one is A and B only, which would be cigarette smoking and heavy alcohol consumption. Cheek biting has nothing to do with it. Which of the following conditions has not been associated with some elevations of the risk for oral cancer? Erosive lichen planus, chronic periodontitis, ingesting 6 or more alcoholic beverages daily, submucosal fibrosis. So the answer to this is B, chronic periodontitis. A persistent red and white lesion in anterior floor of the mouth of a smoker is to be viewed as possibly dysplastic and worthy of close observation, likely to be benign, but worthy of documenting in the chart. A potential cancer with a biopsy mandatory, or D, none of the above. The answer to this one is a potential cancer with biopsy mandatory. Since we know that the patient is indeed a smoker, it is important that if we see something that's not normal, we should be referring them out for a biopsy. Requirements for a thorough oral cancer examination include a dental mirror, a good light source, a gauze square, or all the above. We know this as clinicians, it's all of the above. When conducting an oral cancer examination, it is generally advised to focus on notable findings first, work around the mouth in a reproducible, systematic fashion, look only at the high-risk sites in high-risk patients, or all the above. The answer to this one is B, work around the mouth in a reproducible, systematic fashion. We always follow the same steps when we're doing EOE, IOE. It is often difficult to visualize the most posterior portion of the floor of the mouth. One way to bring more of this area into view is aggressive use of the mirror, pushing up gently on the submandibular region of the neck while retracting the tongue with a mirror, having the patient stick his or her tongue out and saying ah, or none of the above. This would be pushing up gently on the submandibular region of the neck while retracting the tongue with a mirror. An oral lesion is found in an unknown, reliable patient and is judged to be clinical suspicion. The recommendation course of action is immediate scalpel biopsy, remove potential irritants, and have the patient return in 2 weeks, laser vaporization of the lesion, or none of the above. This would be remove potential irritants and have the patient return in 2 weeks. So doing so, we're just checking on the patient. If it doesn't go away, we can send them to an oral surgeon. A 62-year-old male with a long history of cigarette smoking and heavy alcohol consumption is diagnosed with an early asymptomatic stage 1 floor of the mouth cancer when he visits a dentist for an unrelated dental problem. He admits to no significant medical history, no medications, and has no drug allergies. Which of the following statements about this man is most likely to be correct? It is highly likely that he will die of this particular oral cancer. His treatment will likely require a combination of radiation, chemotherapy, and radical surgery. He has a significant chance of developing or has already started to develop separate cancer somewhere else in his upper aerodigestive tract, or all the above. The answer to this one is C. He has significantly chance to developing or has already started developing a separate cancer somewhere else in the upper aerodigestive tract. This is because he's a cigarette smoker and it has been for a while. Dentists and hygienists seeing patients previously treated for oral squamous cell carcinoma should conduct regular surveillance for these patients, view any mucosal abnormalities as a possible cancer until proven otherwise when examining these patients, encourages optimal oral health care in these patients, or all the above. This is all the above. We want to pay close attention to this patient. They already went through it. It can come back. And furthermost going forward, we want to make sure that this does not happen again to them. Which strain of the HPV is closely connected with cervical cancer and some oral cancers? HPV 18, HPV 31, HPV 40, or HPV 16? The answer to this is HPV 16. The prognosis for individuals with HPV associated with oral cancer seems to be a bit better for those with oral cancer related to heavy alcohol and cigarette smoke. A, true, B, false. The answer to this is true. As we said, the HPV and heavy alcohol and cigarette smoke all cause oral cancer. And that is it for this lesson. I hope that everybody has a more clear understanding of oral cancer. And thank you for watching.